The main takeaway from my speech is that pharmacy is changing really quickly, and so is technology. And unfortunately, right now, technology isn't necessarily aligning with how pharmacy is changing, but we're starting to see glimmers of hope. So it's exciting what's coming down the pipeline. So I'm going to start by talking to you about the profession. Now, we know the profession is changing. We know the profession is evolving. We've said this 100 million times. Everybody knows this. It's kind of a given. It's a bit of a truism now. But it's changed a lot, especially in the last 5 to 10 years. So if we go back, say 100, 150 years, we were in the era of handmade medicines. When we made medicines by hand, what we were experts in was how to cook drugs. Right now, that's not really legal to have people who are experts in cooking drugs. But we knew we had chemistry sets. We had ingredients. We understood what they all did. We knew how to put those ingredients together to give you a tablet or a capsule or a suppository. We kind of teach this in school now, but the students are like, you know what, yeah, I get it. I'm never going to see this. There are some exceptions, but for the most part, we don't do this the way we once did. And that meant that we used to be a manufacturer. We were the people that made the medicines. That was our role. Then we got into the era of hand-packaged medicine. So this was when mass manufacturing took over. Tablets were given to us. So an aspirin was an aspirin was an aspirin, no matter where you went to get that aspirin. Whether you were in Alberta or whether you were in Ontario, that aspirin was coming from the same place. That was a major shift in pharmacy because pharmacists used to make them, and now a factory made them. So what did pharmacists do? Well, we packaged them. We became expert packagers because for a time, we actually weren't allowed to talk about these things. We could give you an aspirin, but we couldn't tell you about it. Here's your aspirin. See you later. You know, that was it. There was no, okay, take with food, might bother your stomach. That was it. We could hand it over. And slowly, we were given the scope to actually be able to educate people on this. Here's an aspirin. It's for a headache. Here's an aspirin. It might cause a little bit of stomach upset or a stomach bleed. Here's an aspirin. You might want to take this for cardiovascular risk reduction. Has anybody ever talked to you about that before? That's a huge shift over decades from not saying anything to actually helping a patient choose something like that, right? And for anybody who graduated, I'd say south of 2000, we all remember hand typing these. And now it's one of those stories like you hear the pharmacist who's like in a tornado or an earthquake and they're like, I still knew how to hand type labels. It was amazing. All the young people were like, close the pharmacy, but I knew how to do this. So young people don't know how to do this. This is an old skill, this kind of expert packaging. What also happened here was we had hand ledgers. That's how we managed our inventory. Right, on paper, in books. We have moved now into the more computerized, ready packaged medicines. So what's coming out are things like we have boxes, things that are beautifully blister packed. They've got the days of the week on it. We stick a sticker on it. Birth control is one of the best examples, expertly packaged. All we have to do is put a label on it. The woman gets that package, she opens up that birth control, she has a nice patient-oriented insert inside it. We're all good to go. The pharmacist is almost not even really needed in that sense from a distribution perspective. Very, very straightforward. We're very good at things like we had the Target redesigned labels where on both sides it flattened out so you could have the instructions on one side and then information for the patient on the back end. Most of this generated by the computer. We got very, very good at kind of automating that beautiful packaging that takes over a lot of what the pharmacist was doing. So we became distributors through this. If you look at her pharmacy behind her, she's got all those birth control pills. She's got bags of medication in front of her. And I'm not sure if this is a pharmacist or a technician. She's got all these bottles of mass manufactured products. And in many cases, her primary role is to get those medicines either in those boxes or from those bottles into the homes of the patient. And that really lends itself well to things like robotic distribution. All those bottles and all those boxes I just showed you have a barcode on it, 2D or 3D barcode. A robot is very good at finding that barcode, redistributing those pills into some format, and getting it to where it needs to go. And one of the advantages of that kind of a thing is we can then say to a patient, okay, you got this medication. We know that that medication was recalled based on the barcode that followed along the way and went into your house, and we need you to bring that medicine back and give you a new one. There's all sorts of wonderful things that go along with robotic distribution. The other thing that's changed are technicians. And I know we have a technician award winner who I don't believe is in the audience today, but one of the people recognized today. Pharmacy technicians, man, this has really risen up and taken over a lot of what pharmacists did. So who pharmacists were 30 or 40 years ago is essentially who the pharmacist technician is, or pharmacy technician is today. So combine things like robotics, mass manufacturing, along with pharmacy technicians, and what you get is this kind of new category of distributor. Pharmacy became technical, but you got the pharmacist as clinician. In other words, all along what you did was you peeled away those layers. The person who had to make the medications, we didn't need that anymore, we peeled it away. The person who had to package the medications, I'm not really sure we needed that anymore, we peeled it away. The person who has to get the right medications into the right patient's hands at the right time, actually fairly technical. Robots can do it, and then pharmacy technicians can take over the human component. We peeled that away. And what we were left with was the pharmacist as clinician. And I chose this picture on purpose because what you see is a pharmacist who's a little blurred out, and he's sitting across from a patient. The patient's at the center. The patient can now go and access care from a person in the community around the clock, easily accessible, and they have tons of knowledge. Robots have taken away the workload, so they've got time to give you the knowledge. Pharmacy technicians have absorbed a lot of the workflow, so he has time to give you the knowledge. This is a person who is a health professional. And I teach pharmacy, and some of my colleagues in basic science will really bristle at this idea of a pharmacist being a clinician, because they remember the old school pharmacist. And the old school pharmacist was not a clinician. And I'm not naive to this. I know there are many, many pharmacists now who are also not clinicians, but we're becoming clinicians. Many of us are very much clinicians, and many of us are on that road to becoming a very competent, very effective, very helpful, very knowledgeable health professional. So our focus is changing. We used to focus on the product, and now we focus on the patient. But we say this all the time. What does this mean? So, for example, we focus on adherence now. Adherence in this sense is very much just packaging. This is something that a technician can do, right? We put medications in blister packs. And how many of you at some point have blister packed medications, a patient's got 15 to 20 meds, throw them in a blister pack, send them out week after week after week after week, and never once think about what those medications were in that package? Well, we now have someone whose job that is, and that's a pharmacy technician. Our job is the person who actually says, oh, hold up, I gotta look at this blister pack and figure out what's actually going on here. And all that time you're taking to package it, I'm gonna take that time back, and I'm gonna spend the hour it takes to sort through what's going on here. That's different. The other side of this, though, is that adherence is really complicated. So this is the World Health Organization's model for adherence. And what you see is there are 5 components. So again, this is what we've been thinking of when we think of adherence in pharmacies. This is adherence. Adherence has social and economic factors. So can you afford your medications? Do you have secure housing? Do you have a place you can even have your medications? We've got therapy-related factors. So is your medication taken 5 times a day? Is your medication going to come with a lot of side effects like oral chemo? Is a great example of that. Now people pick up oral chemo. We have abysmal adherence rates because you know what chemo does? It makes you feel like crap. And we want to send people home and say, oh, you got to adhere to that. I know, you're going to feel like you're dying, and you kind of are. But I want you to push through it because it's going to save your life. No, going to hospital helps you through that. Giving people oral chemo at home with horrible side effects, that's a hard sell. Patient-related factors, can they even read the label? Now, if you talk to a lot of your patients, I suspect they understand much less about their medications than you expect. We know that 60% of Canadians have low health literacy. Low health literacy means they cannot or have difficulty either reading the label, understanding the label, or taking the information from a label of their medications and actually applying it in real life. So if you give someone the instructions, take 2 tablets twice a day, roughly about half of people will get that wrong. Just do some mind math. 2 tablets twice a day is how many tablets in a day? Who thinks 2? Who thinks 4? Yeah, so you're all pharmacists. Half of patients would actually come up with 2. right? So this is a major problem that even when they want to, they really struggle with understanding these things. Condition-related factors. So if you have a patient who has to take medication for stroke, but they also have rheumatoid arthritis and can't get the bottle open, or patients who have dementia. Dementia might be related, or patients who are sleeping all the time because of their condition, and it's hard to remember taking their medications. And then you get health system factors, patients who just simply can't get in to see the doctor, or can't get in to see the specialist, or can't afford the parking to get into the building, right? So a really good example of this that happened in my own life was one of my children. I have a 3- and a 6-year-old, and my 6-year-old last year got a skin infection from a vaccination. So we had to give her some Keflex, the antibiotic. And they prescribed it, and it's dose QID, as you all know, which is fine. I didn't think much of it. Went home, gave her her first dose, and it was about dinner time. Put her to bed, woke her up to give her her dose. That's not happening, found that out. No way this kid was going to take a dose mid-sleep. So she sleeps from 7 p.m. until 7 a.m. So 12 hours of my day are now off the table for QID dosing, 4 times a day dosing. In the morning, I give her her dose. I take her to school with the medication, and I said, okay, here's her antibiotics. And they said, oh, yeah, we don't do that here. We don't give antibiotics. I'm like, pardon me, what? No, we don't have a school nurse. So you have to come on your lunch hour, and I teach classes. You have to come on your lunch hour and give her the medications, which is absolutely nuts for starters. And I'm in a pretty privileged role that I have some flexibility, and I still couldn't manage that. I can't imagine what parents do when they can't afford to take that time off. So after a week of QID dosing Keflex, I had less than 50% adherence. One of my big things, like I write into the newspaper and I do all sorts of things, is antibiotic resistance. Like, I believe in this stuff. I believe in actually giving it 4 times a day. And as a mom, I could not get QID dosing into my child. The only way I could have done it was if I took that week off work and stayed home with her to give that to her. So we look at things like this, but we know adherence is much, much, much more complex and much deeper. The pharmacist, as clinician, is the person who manages this adherence. That's different. That's changed. This is the pharmacist clinician, the person who vaccinates. So the pharmacist is becoming the new public health center. And this is great because it frees up public health nurses to do well baby checks, for example, the car seat clinics, things around tick bites. I mean, there's lots and lots of stuff that they want to be doing. So when we can take vaccinations and move them into pharmacies, again, they don't have to pay for parking. It's convenient. Come in and get some milk, and while you're at it, get your flu shot. So this is the start. Flu shots in Ontario, other injections in other provinces. You also get things, though, like melanoma screening, right, and skin-aware clinics. You get things like patients picking up their stool sample tests for fecal occult monitoring. And so what we get is patients when we're screening for colon cancer. In some places in the States, they're actually running that through pharmacies, getting pharmacists to be the reminder to patients that you need to do this, semi-regularly to make sure that you don't have colon cancer. We also focus on monitoring and screening. So it's things like blood pressure, which was talked about earlier, which is great. We've also got other aspects of that, though, as well. So cardiovascular screening, cardiovascular risk reduction, osteoporosis screening is another great example. And then deprescribing, and I present these, every time I present, I always practice with my husband, and the poor guy is not a pharmacist, and he really does not care. So I got to this, and he goes, oh, now you've got my attention. This is the first interesting thing I've seen. So I think that most people don't realize pharmacists are deprescribers. And when I work in a community health center with some physicians. What I do most is stop medications. And the most important question they seem to have for me is, how do I stop this medication? You want to stop 3? How? When do I taper? Which ones come first? What should I worry about? If I stop that aspirin, are bad things going to happen? I don't know. So deprescribing is a major component. If we went back to what I was talking about at the beginning, about manufacturing and about we were the manufacturers and then we were the distributors, we could never have been the deprescribers in those settings because our livelihood depended on filling those scripts, not stopping those scripts. Now, as we've moved so well away from that and handed a lot of those roles over to groups like pharmacy technicians, we can embrace things like deprescribing. And sometimes we even get paid for the good stuff that we like to do. Things like smoking cessation, public health function in many ways. medication reviews, whether we're just making a list or we're doing the best possible medication histories or we're doing medication reconciliation or we're doing actually in-depth reviews identifying what should and should not be on a patient's profile. We're doing disease management, things like diabetes management, geriatrics, so when we've got complex disease management, we've got polypharmacy, multiple competing conditions, all contributing medications. We've got home visits now. We go into people's homes and we see them. And we go back to that adherence model and things start to make a bit more sense when we realize that things are maybe at their home not the way we imagine them to be. When we start to realize that all those blister packs we sent home are only half taken and there's a whole pile of them in the corner. When we realize how much they're really smoking next to their oxygen tank. All sorts of things that we see in a different light, these are things that we're now getting paid for. And some of us can even prescribe. In Ontario, we can prescribe smoking cessation products, but in Alberta, it's amazing what pharmacists can do and how we can use that. So what a shift from a time where we were people who were really kind of the chefs of medicine. We made the medicines and nobody had that knowledge that we did, through losing that role and losing that identity to coming out the other side as someone who is an expert in medications in a way that supports the family doctors who are expert diagnosticians and who see what's going on and who monitor patients, but we actually come in and understand what drugs should be used when and how. And tech is catching up. So you're probably like, when is she going to get to the technology? So here I am, tech. Tech is catching up. All of that matters because technology has not been aligned with everything I've just talked about. It's slowly starting to get there. So we have pharmacy management systems. We've had them for a while, but for all intents and purposes, these are just computerized versions of those paper ledgers, where we track our medications on the shelf, we make sure that we've got the right pills coming in for the expected people who are going to come in this week. We can bill them automatically to the government and those numbers come out. They usually take some tweaking. We have to go in and adjust numbers and things like that. But they're meant to automate a lot of that hand work. What these don't do is account for any of that other stuff I've talked about. They don't give us places for good monitoring smoking cessation. They don't give us places for good monitoring of vaccinations. They don't give us places for good monitoring of complex patients who have polypharmacy and multiple complex conditions. They don't give us good places for monitoring drug lab values, how they correspond to the medications they're taking. And this isn't that much different from what physicians are dealing with. So physicians had paper records, and then electronic medical records came out, and it basically gave them an electronic version of exactly what they'd been doing before, which is, writing down chart notes, place to store lab values, a place to store a CT result or something like that. But what has not happened is these have not created deeper insight into what kinds of patients we're dealing with, how we can have practice-wide interventions that actually impact patient care, how we can really see how things have changed. For the most part, it's still very manual. You're still flipping through screens in the same way you would have been flipping through a paper chart. One of the biggest changes are electronic health records, and I'm assuming, Dr. Crosby, you probably use Clinical Connect as well, right? Yeah, we're in the same area. So electronic health records have been different. Just a show of hands here, who has an electronic health record like Netcare? Some people would have Netcare in Alberta. Other provinces, who else has an electronic health record is a regional health record that exists outside the office. It connects labs, it connects radiology, it connects emergency consult notes or emergency summaries, discharge summaries. Just a show of hands, who has access to something like that? Yeah, so a few people in here. So these are essentially a way of centralizing knowledge so that people can access it. Now in Ontario, pharmacists don't have access to things like this. This particular version's in southwestern Ontario. I have it because I work with a community health center. So one of the things I find is pharmacists who manage INR and warfarins will say, I might get a call and say, okay, you're in the clinic. Can you get on Clinical Connect so that I can see what your patient, we share a patient, what the INR is, because I still can't access that yet. So this technology exists, and it's fantastic, and it is extremely helpful for physicians, and it's slowly starting to trickle into pharmacies, which is great. And then you get personal health records. Who has had an opportunity to access a personal health record here? Their own record. So we've got one I saw in the back. So that's not many, right? Personal health records are the place that now the patient peeks into the chart. The patient gets things like summaries of their visits with the physician, their own lab values, their own blood pressures, their own weights, things that happened at the doctor's office. They might have an activity tracker like a Jawbone, and it can upload the data into a personal health record that can then share the data with the electronic medical record in the physician's office. Life Labs here in Ontario has done something very interesting, where what they're now doing is, when I had to go in and get blood work recently, this is my blood work, and they took my blood work at 11, and she handed me this little pamphlet, and it had a number on the back, and she said, go online and check your own results. I was like, oh my God, that's amazing. So I went home and I signed up, and it was about 6 or 7 p.m., so just after dinner, all my labs were there, and I could see them, which is fabulous. So we actually in Ontario, through Life Labs, gave patients their own lab values before we gave pharmacists access to anything like that. And this is not a model that's unique. Theranos is a great example. Who's heard of Theranos in the States? Very controversial right now. So Theranos has partnered with Walgreens, and what they're doing is you have a menu, and you go into the pharmacy, the Walgreens, and you look at the menu and you say, what blood test do I want to get today? And they've got STD testing, and they've, all sorts of things patients would want. Anemia testing, so it'd be like your CBC. You could do electrolytes, your INR, your thyroid. Patient chooses, patient pays, so the pharmacist rings it up. Then the patient goes over to the phlebotomist, who doesn't know what the patient asked for because it's private. So the pharmacist knows STD testing, for example. The phlebotomist doesn't know that. The phlebotomist takes the blood, and the lab value gets emailed to the patient and the physician if they have one. So in order to enact that, what they had to do in the states that have done this so far is change the laws so patients could order their own lab values. Very interesting, right? Now, Theranos is controversial because they're claiming that they can do all of this with a drop of blood, and that's not really happening. But the model itself has been very interesting. Now, as all of this is happening, everything we've just talked about, so the transition of pharmacy to this pharmacist as clinician, this kind of emergence of electronic records, one of the things you'll notice about the electronic records, everything I just talked about was data collection. We have a lot of systems for data collection. The systems aren't really designed for patient management or patient care necessarily. We also have at the same time the mobile revolution. So I see mobile phones all over the place here. A few people are probably texting or Facebooking as I'm standing here. Totally not offended, I teach young people. But what we have are things like apps, right? So medication apps. These things are a dime a dozen. Really what they're essentially doing is giving you a place like a Word document you would have on your computer, but now on your phone. You can make a list of your medications, you can organize them, and it can remind you to take them. I think I just got a reminder to take a pill myself. So this is, where these get a little bit more complex is you might get a parent, a mom who also can, in her system, this is MediSafe out of Israel, the mom can also have access to her husband's medication, her kids, her mom or dad's medication. When they don't take it, it might text her and say, okay, non-adherence alert, and then, the mom can call and say, don't forget to take your allergy pill, daughter, or don't forget to take your ADHD medication, son, or whatever. So those are really the limits of the apps, but those are the kind of apps that are out there right now for medications. We also have a lot of disease prevention apps, and so if anybody's used MyFitnessPal, you'll know that one of the great things about MyFitnessPal is it's free, and it is purely calories in, calories out. And how many times have you sat down with a patient who's maybe type 2 diabetes, quite overweight or obese, and tried to explain that they don't need to go to the gym and run more, what they probably need to do is eat less. So you have these apps, this has millions and millions and millions of users that are really based around just track what you're consuming, and it's going to try and emphasize for you that you need to be eating less than what you're burning in order to lose weight. And that's not something that you can tell. That's something that somebody needs to understand. They need to understand that it's not a big plate of spaghetti, it's a very small plate of spaghetti, and spaghetti is very disappointing when you're on a diet, right? You might want a chicken breast. It's more fulfilling. So these are things that they go through themselves. Or if I go for a run, the only thing I get is a beer. Maybe that's what I wanted. So what you start to turn that around is, oh, you know what? I went for a run so I can have a beer. That's what these apps are very good at. These apps are good at collecting data and helping people look at their data. And again, that's kind of the limits of where they're at right now. Because one of the problems we have is we don't have good evidence for apps like this. We have good data collection apps, like we have good data collection EMRs, good data collection pharmacy management systems, good data collection EHRs, good data collection pharmacy or patient personal health records. What we don't have is that next level. So this is a great study from De La Vega and Miro in PLOS One in 2014. And here's a quote from the end of it. It's a study looking at pain apps. They say, "We found that pain-related apps that have been reported in scientific journals have not yet made their way into the shops and are therefore unavailable to clinicians and/or patients. Conversely, 283 pain-related apps were available in the main shops, but none of them had been scientifically validated or proven to be effective. These findings are in line with our hypothesis, but the situation is even more extreme than we had imagined." In other words, pain management apps in the market, almost 300 of them, none of them have been researched. Of all the apps that have been researched and shown to improve benefit, none of them are available on the market. Here's a good app coming out of the University Health Network, or Sick Kids, called the Pain Squad app. These are examples of pain apps that we really want to focus on, where they're really doing intentional design. Kids are involved, scientists are involved, clinicians, families, pain managers. But this takes time. So this came out a few years ago. A lot of the early work was just in designing it. Very expensive. It takes hundreds of thousands of dollars to come up with something like this. Then they just go out and pilot test it and test it with people to see if it feels good and what features have to change and how can we motivate them. And once all of that's done, then we can get to the stage of doing trials. And they're just at that stage now, after years of doing this, of finally testing it out. So we have, iTunes stores and Google Play stores full of apps. And the apps based on the research are kind of stuck in research. Research can take a decade. Research for new drugs, research for new interventions, these things can take 10, 20, 30 years. Apps come out, a guy in his mom's basement can push out an app in like 2 hours sometimes, right? So that's one of the challenges. We have good apps. We don't have good evidence for them. The apps we have, we've got no evidence usually. Here's one for bipolar disorder. This is Nicholas et al. In the Journal of Medical Internet Research in 2015. So in general, the content of currently available apps for bipolar is not in line with practice guidelines or established self-management principles. Apps also fail to provide important information to help users assess their quality, with most lacking source citation and a privacy policy. I'm just going to stop there. Bipolar disease or bipolar disorder is what they're monitoring, and they don't have a privacy policy. Think about that for a second. If you have bipolar disorder and you have not told a family member, do you want an app to out you? If you have bipolar disorder, well managed and are working and have not told your employer, do you want your app to out you? This is a major, we talked about stigma and alluded to stigma a little bit earlier. Stigma is really significant with mental health issues or mental illness. And we have apps out there that are being built that don't even include privacy policies, possibly no consideration of privacy whatsoever. Therefore, they conclude, both consumers and clinicians should exercise caution with app selection. So we do have groups that are emerging and trying to support or foster faster innovation, better innovation. So for example, we have the Apple Research Kit. So Apple came in and said, they saw this problem, said, we've got tens of thousands of health apps. What we don't have are good evidence-based apps. So when they created the research kit, they partner with groups like the Mayo Clinic, Johns Hopkins, they partner with Mount Sinai in New York City. They partner with research institutions. The goal being to have apps that they design, that are well designed, that collect data, and that data goes to the researchers, and they can work with that data and get new insights into diseases like Parkinson's disease. At the same time, to work with the Apple Research Kit, you have to go through institutional review boards. They have to be ethical. They have to be smart. So it can be a small research group, but you actually got principles in place that say you can't just be a guy in your mom's basement building an app. You actually have to build something with intention. So we don't have studies coming out. I showed you studies on pain. I showed you studies on a study on bipolar. We have those exact same reviews on diabetes. We have those exact same reviews on cardiovascular disease. All sorts of conditions. It's the thing, cancer. We now just review apps and say, guess what, guys? There's no evidence for the apps on the market. And another paper comes out and says that. Pick a disease, there's probably a review like that. So what we're trying to do is say, be a bit more intentional about it. This is the area that I really work in, which is patient-engaged design. So the other side of this is we're very good at building apps that solve our problems. So if adherence, as far as I'm concerned, adherence is you forgetting. I'm going to build you an app to help you remember. But if you look at that model, we know adherence, again, is much deeper. So patient-engaged design involves going to the patient and saying, how do you manage your medications? Do you have something in your house that you duct tape together? Can I see that? Oh, that's a good idea. Yeah, I can see how that might work. One design firm in the States, what they do is they go out into the community when they want to do redesign cooking tools, for example. And they'll say, okay, we're going to go to a disabled person's house and have them cook a pizza. And we're going to see how they do it. Because much of what they do is going to give us clues into easier ways of doing something. So when they have something duct taped together, that's a clue to us that we need to follow their design cues and build something geared towards that. They go to children and they say, why don't you cook something and let me see how you're cooking? And when children do something, it's a little bit clearer. So one of their best examples is a pizza slicer, where we've got that big handle on it and you're slicing a pizza, and it's very awkward. If you actually look at the physics of it, it doesn't make a lot of sense to have a handle kind of pointed down with this blade and we run it along like this. So disabled people and children, what they would often do is they take that handle, flip it over top, and then use their body weight to cut that pizza. So what they ended up doing, this design company, was redesigning the pizza cutter so it had a handle over top of the blade, so your arm is essentially the handle. And you're cutting the pizza like this. Now, it seems very silly. If you've never had a problem with it, it wouldn't make sense to you. They won big design awards for this because it was a really different way of cutting pizza, but it was a very easy way that anybody could do it. When you make something easier for someone who's disabled, you actually tend to make it easier for everybody. The same applies for health literacy. In my own work, when we work with patients and find out what they can't understand, if we change it so that they can understand it, especially if they have low literacy or English as a second language, what we actually find is it brings up the comprehension of all of the upper literacy groups as well. So making changes for that lowest literacy group improves comprehension in upper literacy groups. So it's a different way of thinking about how we handle these problems. And of course, phones can also be medical devices. And when we turn a phone into a medical device, that's when we start talking about FDA approval. That's when we start talking about Health Canada approval. So examples of that are a LiveCore. Has anybody used an LiveCore ECG case before? So it's an iPhone case. Was that a hand up? Oh no, that was just somebody scratching their head. That's too bad. It's exciting. So what this is an ECG case that looks like this. You put your fingers on the back and it does an ECG. Now Eric Topol, who's a big medical futurist, he's a cardiologist at Scripps in the States, uses these, and he tells this story in his book, The Patient Will See You Now, about how 3 times he was on flights, 3 times they made the announcement, is there a doctor on the plane? 3 times he went, I'm sure it's happened many more times than that. 3 times he went, and it was chest pain, it's a cardiologist, and he used this AliveCore case and found out in one case it was just a woman having an anxiety problem, and they could keep on going where they needed to go. The next case was probably a minor MI, so they needed to land a little bit earlier, and then somebody who had a major MI, and they needed to make an emergency landing. And that was what he did with his smartphone. And he's also testing things like echoes, cardiac echoes on his smartphone. So what was talked about, holding up the phone to your head and getting an MRI, we're actually not that far from some of these technologies. We've got wireless blood pressure meters. This is a French company called Withings. They're in France, and they're really focused on creating wearables for older populations. They have a great activity monitor watch. It's actually just a regular watch with a little clicker in the corner. That as you get more active, it's not a fancy technology. It's just a regular watch with a clicker in the corner that accumulates your steps. In the morning, it resets and it accumulates your steps. Designed for older people who don't want a Fitbit, but really just want a watch that happens to tell them how much they're walking. I showed this picture. My husband's like, oh, I feel lightheaded. So I hope most pharmacists in here are okay with it. Point of care is the next phase. So if anybody's done INR monitoring, you're probably familiar with CoaguCheck. This is a monitor where you can take a blood sample, get a patient's INR, and then adjust their medications at the point of care. Cadith did a good review of this, and they found that lab testing roughly costs around $7,000 a year per patient. If you do point of care testing where a patient takes home a machine like the CoaguCheck machine, it probably costs about $7,300 a year, and that's with the patient monitoring their own and changing their own medication doses. If you have the machine in your pharmacy and the patient comes in and checks their blood INR, or they're at home, check it, and call you, and you adjust the medication, that costs closer to about $8,000 a year. So not that much more, $7,000 versus $8,000 a year. But with these monitors, what they found is, or what the literature shows, is that patients spend more time in range. They have better quality of life because they're not running back and forth to the lab. And they have the same general outcomes. No more bleeds, no more clots. And similar point-of-care tests include serum creatinine, HIV point-of-care testing, strep point-of-care testing, influenza, hepatitis, hemoglobin A1C, lipid panels, and of course personalized medicine, or genomics. That's when we start getting into doing a lab test to see whether or not you actually should get clopidogrel, whether it's actually going to work for you. A lot of this is looking at point-of-care testing. Thus, pharmacists are an access point for primary care. But pharmacies are also an access point for consumer health technology. All of this is starting to lead towards the pharmacy as another primary care provider. Physicians, family docs are the main primary care provider, but we have nurse practitioner-led clinics. We're seeing pharmacists also come into this role. So now the primary care provider is not one person in one profession, but a team of people who provide care in the community. So the consumer technology we're most interested in now are wearables. So these are the typical ones. Who's wearing some sort of an activity tracker now? No one? Like a Fitbit? I've got one. Jawbone. I've got some. Oh, there's hands. You're just reluctant audience. A few people. I'm sorry if you've heard this joke before. My father-in-law likes to call his Fitbit his Fit bitch because it gets him moving. But we're really just activity level trackers. These are accelerometers. When you're moving, this movement is giving you steps. They might have an altimeter as well that tells you whether or not you're moving upstairs. I'm wearing an Apple Watch. Actually, I love it. I thought it would just stress me out. It doesn't. It's quite the opposite. For a research study that we're doing, this is an example of the WebMD app on the Apple Watch. So when I get a reminder, it would actually show me the tablets I'm supposed to take and allow me to track that. I thought this was kind of goofy. My mom has Parkinson's and takes 6 doses a day. She thought this was fabulous. And she's not a techie person. She thought this was a game changer. And it goes to show that sometimes when we look at technology through what we think patients need, we actually don't understand what it is they really are looking for. Sometimes these things have no use for us, but they're very, very useful for our patients. So what's next in the 3 minutes I've got here? I love this, Wearables Plus. You may or may not have heard of this. It's a Waterloo company called Medela Health. They're creating a contact lens. You put it on your eye. Your body is part of the battery. So by putting it on your eye, it turns on the contact lens, and it measures the blood sugar in your tears. And they're arguing, or they're postulating, that you actually have more accurate blood glucose reading in your tears than capillary testing. And so through Bluetooth, it would send your blood sugar to your phone, and in a wonderful world that they imagine, you might have really complex algorithms that help those external pancreases dose insulin, for example. Google's obviously in this space as well. Proteus, they've got the Ingestibles. So now we're not just wearing it, we're actually consuming it. This is a tablet you take. Again, your body is part of the battery, or part of the device. The stomach acid turns on the battery. It signals to what you see, the little patch there beside the phone. It signals to that wearable sensor that you've taken the tablet, and it marks your adherence. And of course, what would a tech talk be without a tricorder? All the Trekkies are like, awesome, and I'm probably going to call it Star Wars, and I'd be like, totally not awesome. But anyway, the Tricorder X competition. If you haven't seen this, it's Qualcomm's competition, $10 million on the table. 7 teams are now, it's now down to 7 teams. There's a McMaster, a Hamilton team that's in this, but there's teams from India, China, the States, and what they are tasked with doing is building the next tricorder, or the tricorder. What it needs to do is measure 16 different diseases, including things like COPD, including things like urinary tract infections, leukocytosis, anemia. There's a whole bunch of them, including optional ones, things like allergens and stuff like that. Without touching you, it's also supposed to be able to measure your heart rate, your blood pressure, your temperature, your respiratory rate, and your oxygen saturation. So we have a lot of engineers and physicians competing in this to create the next sensor that just comes near you and actually diagnoses what's going on. Virtual clinicians are amazing. Some of the research is showing that some patients actually prefer being counseled by a computer. What this is a person you look at. What you don't see is the algorithm behind it that uses the cameras to look at you and the microphone to pick up things. So they say, how are you today? And you say, I'm fine. And that downward inflection, I'm fine. That goes into the algorithm and says, you don't sound fine today. What do you want to talk about? And then when the person maybe turns their head and says, I don't know, the algorithm senses the I-word movement and then says to them, okay, why don't we start with this? So they're really, really smart, kind of creepy, really, really smart computers. And it changes the way we start to think of the healthcare professional. In Japan, where they have an aging population and not enough people to care for the elderly, we're getting robots, so Robot for Interactive Body Assistance, or REBA, they're looking at. And again, it's only a matter of time before we see something like that here. And of course, there are things we need to worry about. So Captain Sully Sullenberger, who you would know from The Miracle on the Hudson, he's the guy who landed the plane on the Hudson River, right? He is actually a big advocate of health safety and translating what we learn from airline safety over into health safety. So one of the things he's written is that we've learned that automation does not eliminate errors. Rather, it changes the nature of the errors that are made, and it makes possible new kinds of errors. And what he's talking about is the fact that young pilots nowadays have everything so automated for them that when things go wrong, they don't know what to do. We automate the easy stuff and we leave the hard stuff. But it was the easy stuff that kept their skills up. And they're seeing this. So the Miracle on the Hudson, this guy knew how to land that plane because he's an old-time pilot who was doing a lot of really in-depth flying, experimental flying, testing out different planes, things like that. So he understood what to do when he hit that bird. A young pilot would have crashed that plane. And he makes the same argument in healthcare. We also have concern over things like the robot pharmacist, or another word for this is alert fatigue. Every time you send off a prescription, especially if you're in places that have a drug information system, your system alerts you to a drug interaction. You send off your medication to maybe a drug information system like PharmaNet if you're in BC. You get your drug interactions back there. It then goes to your insurance company. You get drug interactions back there. The physician's getting drug interactions, and pretty soon nobody cares anymore about drug interactions. They miss the big things. And so we have this other risk too, which is we're just getting tired of it. And so I hope you recognize this. My husband thought it was just a big pile of Legos. It's obviously Back to the Future. Anyway, I wanted to say thank you very much. Thank you.